Hello everyone, my name's Dr. Kathy Knight-Agarwal and I'm an advanced accredited practicing dietitian working at the University of Canberra. I'm the domain lead for medical nutrition therapy and my research interest is in the area of maternal obesity. So throughout the series of lectures that I've been invited to give you, I will weave some of my research and my current clinical experience into what I share with you. So what is overweight and obesity? It's an increase in body fatness or adiposity, which is associated with an increased risk of disease. It's commonly classified using the body mass index, of which I'm sure you're all aware. And this equation for the body mass index is weight in kilograms over height in meters squared. There's been some suggestion in the literature that ethnic specific cutoffs should be used when implementing the BMI in clinical practice. However, this is not universally accepted. Also, I want to point out that waist circumference may be a useful tool for you to use when assessing your patients for overweight and obesity, particularly with those who have a BMI of equal to or over 30. I'm sure you're all familiar with the following in terms of the specific classification of overweight and obesity based on BMI from the World Health Organization and supported by the National Health and Medical Research Council. So underweight is usually classified as less than 18.5, and you can see here that healthy weight is between the range of 18.5 to 24.9, overweight 25 to 29.9, and then the three classifications of obesity, ending in class 3, which is over or equal to a BMI of 40. So these are the cutoffs that you'll use in terms of your assessment of patients in clinical practice. Before we go on to have a look at local statistics, let's firstly have a look at what's happening globally. Worldwide, obesity has nearly tripled since 1975. In 2016, more than 1.9 billion adults 18 years or over were overweight or obese. Most of the world's population live in countries where overweight and obesity kills more people than underweight. And I guess of most importance here is to recognise that obesity is preventable. However, it's extremely complex, and in future slides we'll discuss some of those complexities in more detail. So now let's have a look at what the prevalence of overweight and obesity is in Australia. In 2017 to 2018, an estimated 2 in 3 Australian adults aged 18 years and over were overweight or obese. That's around 12.5 million adults. Men had higher rates of overweight than women. 75% of men and 60% of women, in addition to higher rates of obesity with 33% of men and 30% of women. Also of note is that obesity is more common as an individual ages. 16% of adults in the same time period, aged between 18 to 24 years, were obese, and this is in comparison to adults aged 65 to 74 who had a percentage of 41, so 41% of older aged individuals. So now let's look at what the impact of overweight and obesity has on Australian society. But before we look at some important statistics, I want to define what burden of disease is. It is a measure of the years of healthy life lost from living with or dying from disease and injury. A portion of this burden is preventable, being due to modifiable risk factors. The Australian Burden of Disease Study provides important information on the deaths and burden of disease due to risk factors, and the last report with this information was published here in Australia in 2018. So in this year, 8.4% of the total burden of disease in Australia was due to overweight, including obesity, making it the second leading risk factor contributing to disease burden after tobacco use. Overweight, including obesity, was responsible for the following: 55% of type 2 diabetes, 51% of hypertensive heart disease, 42% of chronic kidney disease, 28% of coronary heart disease, and 28% of osteoarthritis. Of note also is that overweight, including obesity, was the second leading contributor to fatal burden, with 16,400 deaths in 2018, and that contributed roughly 10% of total deaths in Australia. Now let's have a look at some of the causes of obesity, and we'll start with the traditional biomedical model. As you're all aware, energy balance is the result of equilibrium between energy intake and energy expenditure. When energy intake exceeds expenditure, the excess energy is deposited as body tissue. During adulthood, the maintenance of stable body weight depends on the energy derived from food and beverages being equal to total energy expenditure over time. Therefore, if an individual needs or wants to lose body weight, energy expenditure must exceed intake. And conversely, to gain weight, energy intake must exceed expenditure. Therefore, obesity, we know, is caused by long-term energy imbalance. Having had a look at the traditional biomedical model, maybe we should ask ourselves, then, are the causes of obesity that simple? Energy in versus energy out? Well, let's now explore this in more detail. Now, let's have a further look at some of the other issues associated with overweight and obesity and its pathology. In the last few decades, significant advances have been made in our understanding of the pathophysiological mechanisms involved in overweight and obesity. The neuroendocrinal feedback associated with pathological overeating, coupled with physical inactivity, seems to be the major factors governing overweight and obesity. However, apart from this, genetic predisposition, hormonal imbalances, and gut microbial dysbiosis also contribute to the accumulation of fat stores. Adipose tissue is generally considered as a passive depot for the storage of excess calories. Research has shown that it is in itself an active endocrine organ which takes part in energy balance by releasing free fatty acids, pro-inflammatory cytokines and adipokines such as leptin, which help an individual to regulate food intake and insulin sensitivity. In addition, there are various neurobiological mechanisms that contribute to eating in the absence of energy demand and in the absence of hunger. The corticolimbic system, hypothalamus and hindbrain are three heavily interconnected regions that are involved in controlling eating behaviour. These are affected by various visual food stimuli under a number of different environmental conditions, such as fasting, weight loss, overfeeding, exercise, in addition to obesity, to name just a few. And I want to point out the importance of neurostimulators such as serotonin and dopamine, and that they also play a significant role in food intake. Increased serotonergic signalling is associated with decreased food intake, whereas its decrease induces hyperphagia and weight gain. Gut hormones play a very critical role in overweight and obesity. The cells of the gastrointestinal tract sense ingested food and release gut hormones that help to regulate energy and glucose homeostasis through various autocrine and endocrine pathways. An example of this is the glucagon-like peptide signals that, when released, lead to the availability of nutrients to the brain, and in addition, they help suppress appetite. Additionally, leptin secreted by the adipose tissue acts as a signal for energy availability and promotes satiety. In the absence of food, ghrelin is secreted, which sensitizes the brain to the intake of food. So leptin is an adipokine that regulates food intake, energy expenditure, in addition to immune function. So during the progression of obesity, leptin signaling is affected, leading to leptin resistance. A great deal of research has been undertaken in this area with leptin in relation to overweight and obesity. I'd also just like to point out that various bacteria, viruses, fungi, protozoa colonise the gastrointestinal tract, which is interactively involved in immune, metabolic and neurological health. The gut microbes play a major role in metabolism by fermenting non-digestible dietary fibres to short-chain fatty acids such as butyrate, propionate and acetate. These short-chain fatty acids are involved in cholesterol metabolism, lipogenesis, and are reported to play a central role in appetite regulation. Overweight and obese people show a dysbiosis characterised by lower microbial diversity associated with impaired glucose homeostasis and low-grade inflammation. So we've looked at the main causes of overweight and obesity, but to put this into context, we really need to try and understand what Australians are currently eating, especially as future clinicians. This is the main area of your practice, and that is modifying an individual's energy intake and also ensuring a diversity of various nutrients in the diet. When we look at data from the Australian Institute for Health and Welfare and the 2017-2018 National Health Survey, 1 in 2 people aged 18 years and over did not eat the recommended 2 serves of fruit, while over 9 in 10 did not eat the recommended 5 to 6 serves of vegetables in any one day. The proportion of adults with inadequate vegetable intake was similar across aged groups. Fruit intake was worse among young people. More than half of those aged between 18 to 24 years had inadequate fruit intake, compared to 1/3 of people aged 75 years and over. High intake of discretionary foods, as you're all aware, is at the expense of more nutritious foods from the 5 food groups, and may contribute to Australians exceeding, and undoubtedly does, the recommended intakes of saturated fats, simple sugars and sodium. The Australian Dietary Guidelines recommend to limit intakes of drinks high in added sugars, as they can provide excess kilojoules with little nutritional value and can increase the risk of excessive weight gain. In the period 2017 to 2018, just over 9% of adults aged 18 years and over consumed sugar-sweetened beverages daily. And if we take a step back, in the period 2011 to 2012, we know that energy intake from discretionary foods on a daily basis ranged from 33 to 36%. Low levels of physical activity are a major risk factor for the development and maintenance of overweight and obesity, in addition to a number of other chronic health conditions. People who do not undertake sufficient physical activity have a greater risk of developing cardiovascular disease, type 2 diabetes and osteoporosis. Being physically active improves mental and musculoskeletal health and reduces other risk factors such as overweight and obesity, high blood pressure and high blood cholesterol. In 2015, 2.5% of the total disease burden was due to physical inactivity. Physical inactivity contributed between 10 to 20% of the individual disease burden from diabetes, bowel disease or bowel cancer, uterine cancer, dementia and stroke. So what are some of the other factors that play a major contributing role to overweight and obesity? Well, epigenetics for one. And this essentially is the area related to the early origins of disease in utero and then health outcomes for offspring later in life. Many factors during pregnancy can impact an offspring's epigenetic status, including the health of the mother. A number of studies have identified particular locations within the genome where methylation patterns, for example, of the offspring, have been altered by the mother's gestational diabetes status. In addition, maternal weight during pregnancy has also been associated with altered methylation patterns in the child's DNA and later infant adiposity. Offspring in both underweight and overweight mothers have also been shown to have altered DNA methylation patterns. And this may be related or is related to either high pre-pregnancy BMI or excessive gestational weight gain, or both. Stress and psychological factors also play a contributing role in the etiology and the maintenance of overweight and obesity. When an individual struggles with mental health or low self-worth, for example, they may develop into more serious conditions such as anxiety, depression, or even an eating disorder. This often then follows on to emotional eating, poor self-care, with sometimes little interest in regular exercise. So some of the main psychological factors that maintain obesity may include low self-worth, poor body image, self-criticism, negative core beliefs, and binge eating. We know the quality of the diet may exert its effect on energy balance through a number of very complex hormonal and neurological pathways that influence satiety and possibly other mechanisms. But I just want to point out here, and this is something for you all to think about, and I'm sure you're all aware of anyway, that our food environment, which includes the marketing and constant bombardment of unhealthy foods, also plays a contributing role to overweight and obesity. In addition to urbanisation and, for example, a lack, although that's changing, of green spaces for people to be able to exercise. Unfortunately, further discussion around these factors is beyond the scope of this lecture, but like I said, really important issues to think about. I just thought it was important that I put in a couple of slides here about the metabolic syndrome. This syndrome is important because it identifies patients at increased risk of cardiovascular disease, diabetes, and chronic kidney disease. Those with metabolic syndrome are 2 to 3 times more likely to develop those chronic health conditions compared to people without metabolic syndrome. Metabolic syndrome also increases the risk of complications in those with cardiovascular disease and diabetes. Research suggests that there is up to a 1.6-fold increase in mortality in patients with the metabolic syndrome compared to those without it. So, what are the key defining features of metabolic syndrome? Well, excess abdominal weight, lipid abnormalities such as low HDL and high LDL, hypertension or high blood pressure, and elevated glucose levels. This slide gives you the diagnostic criteria for those different diagnostic elements of metabolic syndrome, and I will leave this slide for you to review in your own time. This concludes the first lecture in this series that I'm giving you, and I've just put up on this slide here some suggested reading that will further consolidate your learning of this topic.